Good morning. My name is Patrick Robbins. I'm a fourth-year general psychiatry resident at the Medical University of South Carolina in Charleston, South Carolina. My primary mentor on this project has been Dr. Ben Kalivas of the Departments of Internal Medicine and Psychiatry. Benzodiazepines are very common in the hospital setting, with some estimates of being up to 30% of hospitalized inpatients receiving a benzo at some point during their admission. In addition, they're maybe the most notorious deliriogenic medication, but the exact relationship between delirium and benzodiazepines is difficult to assess. While benzos may be known to contribute to delirium, they are also often used, and potentially inappropriately used, as a treatment for delirium-associated agitation, thus creating a chicken or the egg scenario when attempting to study them. We used large data to determine the association between benzos and delirium at our institution, as well as the temporal relationship between benzodiazepine administration and delirium onset among our hospitalized inpatients. For our methods, we gained IRB approval for a retrospective analysis. We included all adult inpatients from August 2018 through January of 2020 for an 18-month time window. We excluded patients with zero delirium screens or with an alcohol-related diagnosis, as this can change the relationship. As part of a hospital-wide delirium screening protocol, all of our adult inpatients were screened twice daily with either the brief confusion assessment method for non-ICU patients or the CAM-ICU for ICU patients. These were screened by nurses twice a day and then inputted into the EMR as a positive or negative value. And then we queried the EMR for those screening results, med administrations, as well as other demographic factors and hospital factors. For our definitions, we defined a patient as benzodiazepine positive with any benzo administered during their hospitalization. This is a dichotomous variable, a qualitative variable, not quantitative. So if they received a benzo, they are categorized as benzo positive. If they didn't, benzo negative. Similarly, with CAM positive, we categorize patients as CAM positive, delirium positive with any positive delirium screen during hospitalization. We did not account for a different number of positive delirium screens. So either zero screens, which would be CAM negative, or any positive screens, which would be CAM positive. Once we had our benzo positive and CAM positive groups, we looked at patients who were both benzo positive and CAM positive, and then defined temporality by the first event, whether they received their first benzodiazepine first or their first positive delirium screen before receiving any benzodiazepines. We did a univariable analysis for CAM and benzo status, and then a multivariable analysis performed with CAM positive as the outcome of interest. For our results, nearly 37,000 patients met our inclusion criteria, and then we excluded just over 7,000 patients as part of one of our two exclusion criteria, leaving us with a final study population of 29,598. For our overall delirium rate, we can look at the bottom left pie chart, where in blue, we had 4,342 patients for a delirium rate of 14.3% of all hospitalized patients during this time window screening positive for delirium at some point. This is a little bit lower than previous values, where rates have been between 20 and 30%. A possible explanation of this might be that this study was a hospital-wide sample as opposed to previously more studied high-risk populations such as ICU patients, elderly, or post-operative patients. For our benzodiazepine administration rates, we can look at the middle pie chart, where also in blue, 11,859 patients received a benzo during their hospitalization for a rate of 40.1%. There are many possible explanations for this. One might just be that this is an institutional practice that we might be able to investigate and potentially improve upon further. In our 2x2 table, on the right we have benzodiazepine positive patients, and then on the left we have benzodiazepine negative patients. Of benzo positive patients, I don't have these percentages here, but benzo positive patients, 23.3% of them were CAM positive at some point versus only 8.9% of benzo negative patients. So this is a univariable analysis that was statistically significant. For our temporality, we have to look at the bottom right quadrant of our 2x2 table, where we had 2,765 patients who were both benzo positive and CAM positive. Of those double positive patients, we can look at the bottom right pie chart, where in blue, 57.4% of them received their first benzodiazepine before any positive delirium screening. So benzodiazepines preceded the delirium for these patients, as compared with 42.6%, which had a positive delirium screen before their first benzodiazepine. On multivariable analysis, looking for CAM positive and controlled for all the following factors, benzodiazepines were statistically significantly associated with CAM positive with an odds ratio of 2.6. Stronger association for ICU status, age above 80 and 65 to 79, and then antipsychotics, we have the temporality data. Weaker but still significant for in single, marital status, not statistically significant poverty and distance, DMSC, and then negative associations for actually anticoagulants and opioids. So the key points for this study, benzodiazepines and delirium are common in the inpatient setting. They are associated on both univariable and multivariable analysis. The association is weaker than factors such as ICU, stronger than demographic factors, and benzodiazepines are more likely to precede delirium than to follow it. However, a significant portion of patients will receive benzodiazepines after they've already been found delirious. So there's avenues for further investigation here, but I'll stop and hold for questions at this time. Thank you very much.